Good morning, everyone. We'll wait just a moment while more folks will be joining our webinar, and then we'll get started. So we'll begin in just a moment. If you're just now joining, we're waiting for more attendees to join us, and we will begin in just a moment. We're seeing our attendance numbers rapidly rise, so we'll wait just another moment before we begin this morning's webinar. We're so glad you're with us today. All right, I see it's 9:02. Our numbers are still rising, but I think we'll go ahead and get started. Welcome. We're so glad that you took time to join us this morning. We think we have a really important program to present to you today, and we're glad that you're here. While we're waiting for others to join, we'd like you to answer our first poll question, and that's going to be on the screen in a moment. We would love to know what state you represent. If you could please just make your selection and then hit submit, that would be great. We will have several polls this morning, so get used to this. This is going to be something that we'll ask of you as we go through. We'll have 4 different poll questions, and we really do appreciate your participation. So we'll give you just a moment as you're joining to select what state you represent on our poll on the screen, and then hit submit, and we would appreciate that. All right, thank you very much. We appreciate your participation in that poll. Let's go ahead and get started. Good morning, my name is Deb Dillingham. I'm the Senior Director for Cancer Control Strategic Partnerships in Ohio and West Virginia. It certainly is my pleasure to welcome you this morning. We ask that if you've called in by phone, that you please enter your name and organization in the Q&A so we have record of your attendance. All lines will be muted during our presentation this morning, and we ask that you enter your questions into the Q&A tab on your screen. We will be taking questions at the end as time permits. If we don't have time to answer your question during the Q&A, we'll work with the presenters post-event to have your questions answered. All right, if we could remove the poll and move to our next slide, please. I now have the pleasure of introducing to you our guest speaker, Sylvia Sanderson. Sylvia Sanderson is 39 years old, a mother of 3 human children and to many other species. Sylvia just celebrated her 20th wedding anniversary with her high school sweetheart. She's been a member of the Medina Relay for Life since 2007 and became entertainment chair just a couple of years later. She's a Cub Master, a Girl Scout leader, an active leader in her Scouts BSA troops, and she volunteers for Rescue Village, Medina Swarm Agility Club, and her schools, Green Elementary and Green Middle Schools in Smithville, Ohio. Sylvia was diagnosed with invasive ductal carcinoma in the beginning of May of 2020. It was metastatic breast cancer, and she found that she also had the BRCA2 gene. Sylvia went through chemotherapy, radiation, surgeries, and hormone therapy. She has since become an ACS CAN member and a voice of hope for the American Cancer Society. Let me turn it over to you, Sylvia.
Thank you so much, Deb. Hi, everybody. I'm Sylvia Sanderson. I'm here to share with you a little bit of my story to let you know why breast cancer screening and the breast and cervical cancer program is such an important thing and why we're backing it. So very early on in 2020, I would say April, I felt a lump. We were right in the middle of COVID, so things were going really crazy. I hadn't been working. My husband, hours had been cut about in half. Insurance was just not a thing at that point for us. And then I felt this lump, and I knew better than to wait because I had been a volunteer with ACS for so many years. So I called the ACS hotline, and they directed me to the Breast and Cervical Cancer Project in my area. That program is what I like to say saved my life. I was 39, or well, actually, I'm sorry, I'm 39 now. I was 37 at the time, and I wasn't even eligible for mammograms or screening and went with our insurance. You had to be at least 40 to get that covered anyways. So I contacted them, and they were able to get me connected with people in the area that got me right in for screening right away. I mean, I was in for a visit with an oncologist the next day. I went for a mammogram the day after that. 2 days later, I was back for a biopsy. It was so fast how they got me in and everything happened. It was scary, but wonderful all at the same time to see that program. I mean, it helps so much. We found out that I had a 0.5 millimeter sized lump, and as small as that sounds, it's about the size of a pea. It had already metastasized to a couple of my lymph nodes. So if we had not found it that soon, I would have been in big trouble, big trouble. They realized that I had a stage 2, but level 3 breast cancer. And it was level 3 because it was so aggressive, which meant had I waited another couple months, my story could have been a whole lot different, and I might not be here with you guys today. So the Breast and Cervical Cancer Project then got me signed up with their insurance, with their program. They were able to get me into my treatments right away. I didn't have to wait, which again, huge for as aggressive as my cancer was. I was able to get right in and start treatments a week after they put my port in. I spent all summer doing chemo. I did 3 different types of chemo in 2 different rounds. After that, we did a double mastectomy. After that, we went right into radiation. And at the end of the radiation, and I healed up a little bit, we did a hysterectomy as well, because we then found out that I was positive for the BRCA2 gene. And as some of you know, that gene can cause cancer in the reproductive system as well. So to be proactive and to make sure that I'm here for my kids and don't have to go through all that again, we went ahead and did the hysterectomy and got all that taken care of as well. It's one of those things that I'm going to be living with for pretty much most of my life now, though. I'm on hormone therapy medication that I'm going to be on for several years. And then even after that, the effects of it are just still going to be being watched. And I have to be super careful with so many things that you just don't think of. But the breast and cervical cancer program was absolutely huge in getting my early screening done. And like I said, the reason why I'm here is because of them and my early screening that they were able to get me in for. There's been noticeable, there's been notable advances in cancer prevention screening. Not all individuals benefit equally from the progress of this, though. So today you're going to be hearing from experts in oncology discussing the disease burden with an emphasis on the disparities in prevention and early detection. You're also going to hear from community partners that are sharing innovations in breast cancer screening that have been implemented in the institutions, along with tools and resources that you can use to reduce the barriers and increase screening rates. Some of this stuff is so crazy when you look at the stats about early detection. I mean, uninsured women overall between 40 and 64 are half as likely to have got their mammograms in the past 2 years than uninsured women. And like I just said, that's a huge thing. Please get them done. Asians, Hispanics, and Latinx, American Indians, and Alaskan Natives are least likely to be screened for cancer due to not having usual source of care. African American women have the highest breast cancer death rate and are less likely to have screening at high quality facilities. So they have less access to 3D mammography, which has a much higher detection rate and lower recall compared to older technologies. So ACS CAN advocates for increased funding for the National Breast and Cervical Cancer Early Detection Program, and that provides cancer screening to low-income, uninsured, or underinsured women, a majority of which are women of color. So ACS and ACS CAN are fighting to achieve health equity and just fair opportunity for everyone to prevent, find, treat, and survive cancer, regardless of how much money you make, the color of your skin, your sexual orientation, gender identity, whether you're on disability or not, or where you live. That just should not decide if you are going to survive this battle. So at this time, I would like to go to the next slide and recognize our sponsors. A thank you to our presenting sponsor, the James at Ohio State University, with support from the Ohio Partners of Cancer Control and Mountains of Hope. And also a special thanks to the OAFP for being our CEME provider. I'm going to turn the program back over to Deb Dillingham, and she is going to review the agenda with you guys. And I thank you for having me along as your speaker for today.
Sylvia, thank you so much. Thank you for sharing your story. Thank you for sharing the importance of this battle and the equities issues that we're concerned with today. Thank you. We appreciate it.
Thank you.
Let's take a look at our agenda for the day. So we're going to begin this morning with health equity and breast cancer screening with Dr. Bridgett Oppong as our featured speaker. Next, we'll be joined by staff from the American Cancer Society Cancer Action Network. Just as Sylvia referenced, they'll share with us some of the updates this morning. This will be followed by a breast cancer screening panel with 3 of our partners. And lastly, you'll hear from Ashley Dedman from the National Breast Cancer Roundtable. Take a look at the next slide, please. The AAFP has reviewed Health Equity and Cancer Virtual Series Breast Cancer Webinar and deemed it acceptable for up to 2.0 Enduring Material Self-Study AAFP prescribed credits. You'll receive a certificate to claim your CEs within 2 weeks following today's event and the post-event survey. Our objectives for today's event can be seen on the current slide. Please note that the planning committee members and the speakers have declared that there are no relative financial arrangements or affiliations with any organization that may affect balance, independency, objectivity, or scientific rigor for the CE event. Also, please know that slides will be available after the presentation and that this event is being recorded. Now, let's get to our second poll before I introduce our first speaker. If you would, you'll notice the poll pop up on your screen. Please let us know what sector you represent. We'll give you just a moment to select the sector you represent, what best represents you. And when we see voting come to a slow, we will go ahead and introduce our next speaker. We'll give you just a moment to make your selection and hit select. Hit submit. We very much appreciate your input this morning. Thank you so much. And we're going to go ahead and introduce our guest speaker for today. I'm really pleased to introduce to you Dr. Bridgett Oppong. Dr. Oppong is a surgical oncologist who treats patients with breast cancer. As a member of the Cancer Control Program at The Ohio State University Comprehensive Cancer Center, the James, she has an academic interest in disparities in breast cancer outcomes with a focus on research. Her current projects involve exploring disparities in the receipt of care through breast cancer continuum from screening to treatment. She's also developing studies to investigate the impact of biology in regards to breast cancer tumors and patient characteristics, such as metabolic syndrome. In addition to her clinical and research work, Dr. Oppong serves as the Deputy Director for the Center for Cancer Health Equity at The Ohio State University Comprehensive Cancer Center, the James, and as Associate Professor in the Division of Surgical Oncology at The Ohio State University College of Medicine. Welcome, Dr. Oppong.
Thank you so much. Thank you for that wonderful introduction. And good morning to everybody. Welcome to this wonderful webinar. I'm very excited to be presenting. And I'm very excited by the numbers that I see coming here. This is such an important issue to me that it's really inspiring to see that it's early and it's Thursday. I mean, it's not Friday, but it's close enough that I'm excited to see so many people on here. So again, I don't have any disclosures. And just to begin, I will be talking about health equity in breast cancer screening. I'm sorry, next slide. So my objectives will be to explain breast cancer epidemiology. We're going to learn about risk factors of breast cancer. And really the meat of this talk will be discussing controversies in screening and how this is related to disparities in screening utilization and ultimately the need for equity. Next slide, please. So just as background here, again, from our sponsors, American Cancer Society, a graph showing the trends of cancer incidence or new cases over the since 1975, the last decades. And thankfully, we do see overall a decline with both men and women. Next slide. With that being said, we still see a lot, unfortunately, of new cancer diagnoses. And this is going to continue to increase as our overall population ages. But estimated for 2022, about 31% of all cancers diagnosed in women will be breast, the most common, whereas in men, it will be prostate. Next slide, please. Now, when we focusing more on breast cancer, I quote a patient's 10% lifetime incidence or risk, right? This equals about 1 in 8 women, American women, being diagnosed. And an additional harrowing statistic is that this means that every 3 minutes we see a breast cancer diagnosis. So it's really important for us to keep that in mind as we're sitting here this morning. Every 3 minutes, unfortunately, a woman's life will be changed permanently due to this diagnosis. What this means is that, again, as of this year, ACS estimates approaching 300,000 new cases of invasive breast cancer, 50,000 new cases of intraductal disease, as well as, unfortunately, 43,000 women will die of breast cancer. Next slide. So there are risk factors that have been established for breast cancer, with the first 2 being the most predominant, as being female or having a large amount of mammary or that's breast tissue, as well as older age. And I mentioned before, as the population ages, we will continue to see more cancer, including breast, obviously, as the most common. But there are also other factors. And if you look to the pie chart here on the right, 70% of women diagnosed are categorized as what we call sporadic, meaning that there's no familial predisposition, there's no mutation. We don't have a causal factor in this. There's also a smaller subset, about 20%, who will have a familial predisposition. And within the subset, only about 10% will have a known mutation when we do test. Additional information on the risk factors. If you look at the items that I've highlighted in red, those are more newer or emerging risk factors that we're continue to really gather information on, with high breast density, mammographic density being a huge risk. Excuse me, we can go back. Sorry about that. And also alcohol intake and obesity currently, as the whole country battles with this obesity epidemic, we're starting to see that also as a risk factor for breast, but also other cancers, including colorectal. Next slide. While, as I showed you in the beginning, overall new cases of cancer seems to be declining over the last decade, we still obviously see a lot of breast cancer. Now, historically, there was a difference comparing Black and white women as far as new cases or, again, incidents. However, in recent times, this difference has really gone away. And now we see a similar breast cancer incidence between Black and white women. And I have some data from our Ohio patients, and we see that roughly the new cases is roughly equivalent for Black and white women. Next slide. Now, where we do have a sustained and important difference is in outcome, right? So there's still a persistent mortality differential, and this difference is highest comparing Black and white women, and we still see about a 41% excess mortality in Black women compared to their white counterparts. So we see here, again, I have our local Ohio data. Unfortunately, I don't have race comparisons for West Virginia because of the smaller population of Black women. But what this means is that the 5-year survival outcomes are about 78% in Black women compared to 92% in white women. So this is really, again, a really sort of disturbing trend that we're seeing and we need to address. Next slide. So what some of the factors that we see related to this poor prognosis is tumor biology. So there's certain types of cancers that African-American women get more than others, and we'll review a slide on that. There's also underlying patient comorbidities, including obesity, and some things like hyperglycemia or having diabetes. Those are all things that may complicate treatment. There's also inadequate receipt of treatment based on access. You can go back, please. And then certainly last but not least, we're going to spend a lot of time on disparities when it comes to screening and Black women presenting at a later stage of diagnosis. Next slide. So again, on triple negatives, this is the lesser common subtype of breast cancer. About 70% are actually estrogen positive. And most of the therapies, especially targeted therapies, are focused on this subset. So triple negative breast cancers have a worse prognosis, in part because the treatment options are limited, especially when it comes to systemic treatment. But unfortunately, Black women are more likely to be diagnosed. And also, this compounds the fact that Black women are diagnosed at younger ages compared to their white counterparts. Next slide. Okay. All right, so Black women, as I previously stated, are also diagnosed at later stages. So this is from Dr. Lisa Newman. And it shows that when you look at the more advanced stages 3 and 4, Black women are more commonly to be diagnosed compared to white women and also compared to Hispanic women. Next slide. Now, this particular sort of aspect of disparities was very interesting to me. And this is a study, one of the first studies that I did at my previous place of employment. And to me, it was very interesting because Washington, D.C., for those of you who don't know, has about 50, probably at that time, 60% Black population. It also has a much higher concentration of educated, socioeconomically more middle and higher earning Black population. So I actually looked at our data because I anticipated that this difference in stage of presentation would not still persist. And unfortunately it did. 18% of the Black patients presented at stages 3 and 4 compared to 11.5% of Black patients. And certainly the subset that had public insurance, Medicaid, for example, were even more likely to be diagnosed. Next slide. So with that concern that we're seeing increased mortality, and part of that is that Black women are presenting at later stages, is mammography utilization the key, right? So are we underutilizing or are we not screening Black women appropriately? Next slide. So the benefits of screening, I don't think I have to convince many of us here about the benefits. We all believe in this. That's why we're, even at this webinar. Next slide. But there is established data that mammography does reduce breast cancer mortality, especially in the older subset, women age 50 and over, by as much as 30%. Now, there is some controversy with the younger ages, but even in this subset, most studies do conclude a benefit. Next slide. Additional data supporting the benefits of mammography, this is a survival analysis on patients. In the blue line, you'll see patients who are diagnosed with a mammogram detected cancer compared to patients who are diagnosed based on the patient's findings or the physician exam. And you can see that there's a persistent difference in survival. Next slide. So again, I don't have to convince many of us here, we believe in this. We know that the screening is important because it can find breast cancers early when it is most treatable and most manageable. Next slide. It doesn't mean that this is without controversy, right? So we all agree that if you want patients to get mammograms, they need them, but there's still controversies when it comes to frequency, when it comes to adoption of new technology, as well as who and when patients should get supplemental imaging. Next slide. All right, so the guideline changes, this was about 2015 when ACS went from recommending annual screening at 40 to 45. And actually, we go to the next slide. Other offices, other bodies, other societies had their own recommendations. So this has created a bit of a, I don't want to say hysteria, but certainly definitely some confusion for those of us who do community work and engagement. The U.S. Preventative Task Force went from starting at 50, and then every other year, ACOG stayed with 40, and American Cancer Society stayed at 45. And as a breast surgeon, our society also had their own recommendations, and we never really veered away from the start initiating at 40 and recommending annual exams, right? So with that being said, all of these agencies, however, and societies still have, there's always a fine print, right? That they want the patients to be, or the recommendations to be individualized and tailored to the individuals based on their family history and based on their individual risk assessments. Next slide. So this is a part of that whole push. Again, the U.S. Preventative Task Force, for example, has not commented on this particular issue as far as Black women due to the worst outcomes being screened at a different, initiating at a different time. But ACR, the American College of Radiology, and Society of Breast Imaging, as of 2018, did release different screening guidelines that, due to the elevated risk that, as I've shown you previously with the data for Black women, that they should get screened earlier. All right, so this is something that I definitely a proponent of. I think it deserves a lot more investigation, a lot more attention, and I slowly but surely, I think that there will be movement towards it, because if we consider some of the data, the disparities data that we have, this is very analogous to prostate cancer, for example, and the prostate cancer recommendations have been changed to reflect the elevated risk to Black men. So now Black men are recommended to start screening at a younger age, and I hope and I would like to foresee that happen also for breast cancer. Next slide. All right, so now another controversy, now not as new, not as imminent, and I think we talked about it earlier this morning, is new technology. 3D is sort of the lesser new of things. Like now, for example, at our breast center, we're doing contrast enhanced mammography, right? So 3D is something that has a higher detection rate, about 35% improvement from the standard 2D mammography. And if you look at the imaging below, you can see a big difference. Like if you look at the 2D image on the left, really you can't discern much, right? There's too much density. There's some parenchymal thickening. But if you look to the right, with the additional of the tomosynthesis, that you can see a discrete mass. So it's been very beneficial. And this is something that we need to advocate for, that all screening centers, adopt this more advanced or this more improved imaging technology. And we also, I think our wonderful speaker this morning mentioned that there is some concerns about underserved communities not having these newer technologies at their imaging centers. So that's something that we need to also consider. Next slide. Additional imaging modalities include automated breast ultrasound. This is a depiction of that. And this is something that can be used for supplemental imaging, right? And I'll go into a little bit information of what sort of leads patients to get this recommendation. Usually is density or having atypia or some other marker of elevated risk. But this is the ABUS, and I want to have it out there because patients ask us about it all the time. Next slide. Another modality when we talk about supplemental imaging is the MRI. That's personally what I'm most familiar with. I find that the ultrasound is really operator dependent. So if a patient has high density or has other risk factors, I tend to recommend recommend the MRI more. And here's a depiction of that. Next slide. And again, these supplemental imaging are really important when we consider breast density. Next slide. And this is just a quick depiction explaining what density is. It's the ratio of fatty tissue to the glandular elements within the breast. Next slide. And why it matters really is the impact on the imaging quality, right? So if you look at, this is the BIRAS categorization for breast density. Level 1 is a fatty breast, which you can see it is from a radiographic aspect is easier to detect an abnormality compared to if you look at the level 4 or extremely dense breast, where you can see there's a lot more whiteness, there's a lot more parenchymal tissues or elements that make cancer detection more difficult. Next slide. And the other part, then, this is again more newer or emerging data, is that breast density, not only is it important as far as the impacting the imaging quality or the readability of the mammograms, but is also in itself is a marker of risk, right? So women with the higher levels 3 and 4 categories, 3 and 4, breast density have a 70 are 4 to 6 times greater to develop breast cancer. So that's something that I look at, and oftentimes if the woman is very dense, then I will recommend supplemental imaging. Or you'll see it on the imaging reports. So part of the whole, as the knowledge of density has become more robust, it's been incorporated now into sort of the mammogram report, right? So patients should be given, all of us should have information on our breast density, and based on that, a possible recommendation, or at least a statement stating that density is elevated and that the patients can be considered for supplemental imaging. Next slide. And additional recommendations that we use to sort of discuss or recommend supplemental imaging is overall breast cancer risk, right? So the risk assessment is really important. And I know someone just wrote something in the chat about family history. That's really sort of the first. You want to know all the first and second degree relatives. You want to know the age of the youngest affected member. And it's not just breast cancer, right? If you look at for BRCA1 and 2 mutation carriers, there's also a risk for colon cancer, prostate cancer, lots of other disease sites that patients don't even think about telling us when we see them in our offices. But these mutations are very important. And if the family history is of concern, then we recommend genetic counseling and testing. And I have the picture here of Angelina Jolie just to remind me to say a lot of even providers, you know, I have to be honest, I talk to people all the time, colleagues, and everybody sort of assumes that these mutations, for example, are more common or more prevalent in white populations, when the reality is that all women who meet criteria should be tested regardless of race and ethnicity, and that we see these mutations in everyone. All right, the other risk assessment tools can include the Gale models or IBIS. IBIS is what I particularly use because it does incorporate breast density into the risk assessment. And based on these tools, if a woman's lifetime risk is 20% or more, then that also is a way for us to justify recommending supplemental imaging with an MRI or ABUS. Next slide. So how are we doing? What is the state of our current screening numbers? Next slide, please. So here's our goal for 2020, which obviously now we're at 2022. So we did fall short, you know, and this is despite all the efforts, and I know we'll hear a lot more about some of the programs and all the wonderful things that many of you are doing, but ultimately for 2020, we didn't quite make the target. Next slide. And this is all races. And part of the reason that really we didn't make that target is that certain subsets within the country, certain populations are underscreened, right? So there's a persistent disparity in screening mammography. And this particular systematic review found that African Americans and also Hispanic women tend to underutilize screening. And it was just such an extensive paper that they actually localized their findings to a subset that were within the 40 to 65 year range, right? So in African American, it was the younger subset. And then also conversely, it was the patients over 65 who were not getting screened appropriately. Next slide. All right, so we still have some work to do. As we see, 2020, we didn't make it, we didn't make our goal. And there are some established barriers. Historically, we've seen poverty, lower education, worse health status, and lack of insurance. So a lot of the social determinants of health that present as barriers to mammography attainment. There's also some cultural nuances that we need to consider. So that certain beliefs, fatalism. I've had patients who, whether they engage in the healthcare system at all, but they certainly are very fearful of getting mammograms. And again, before coming to Ohio, I worked in DC, and Washington actually has universal healthcare coverage, right? So all patients who don't have insurance can qualify from some level of support. So it wasn't the reality that they didn't have access or insurance to get to the mammograms, but even when they were given coverage, patients still weren't doing it. So that's really the subset that we have to focus on. Once you do the education, then you have to sort of dive deeper to see what the barriers are that are limiting or preventing patients from obtaining screening. Next slide. So as we do that work and try to identify these barriers and try to address them, hopefully we'll make our target for 2030. But again, we need to emphasize the low utilization rates in certain subgroups. So it's not just, previously we say we focus on Black patients, right? But as we've seen, we have to look at Black patients in certain geographic areas. We have to look at Black patients within certain age groups. Those are the ones that we need to target, because I think, again, it's a testament to all the wonderful work that, this breast cancer, the whole community has been doing, is that we have positively impacted breast cancer screening, but there are certain groups that have been left behind. All right, so ultimately, to improve breast cancer outcomes, I really believe a huge part of our efforts, despite the research and needing to come up with new therapies, is that we need to increase mammography uptake. And this message is really pertinent, it's really important at this time because of COVID, because those were some structural barriers that had to happen, of course, but we know that it really disproportionately impacted patients who are otherwise at high risk for not getting their screening anyways. So I look forward to sort of seeing some data in the future to see how the screening numbers have changed. But we need to increase overall uptake. We need to increase awareness and educate the community on screening guidelines. Of course, it's very confusing that there's multiple guidelines to follow, but ultimately I tell patients, listen to your doctor, tell them your family history, and so they can advise you properly and tailor your screening. All right, we also need to encourage healthy lifestyles. One slide. And again, our focus should be on Black patients, just because of the outcome differential. Not to say that there aren't other populations. There are disparities in rural women, there's disparities in Hispanic populations. Those are all very important. And I am sure we'll hear about some of the work that all of y'all are doing, but at least my particular focus and interest is on addressing this with the Black community because of that really, really disturbing outcome differential. That 40% excess mortality is more than any other group. All right, next slide. So again, I'd like to acknowledge just so many people that help me do what I do. First and foremost is the Center for Cancer Health Equity, for all of the outreach. And we have a massive team. This is a massive enterprise when we talk about addressing cancer equity. First, we have to find out what the inequities are, right? We have to see what certain communities are lacking, and then you have to find a way to address them. So we're always working and looking for ways to tailor our approaches and to adapt, especially as the community in Columbus adapts. We see we have different immigrant populations that we also need to include in our efforts. I'd like to thank my department because I'm, primarily a breast surgeon. So all of their support and allowing me to do really non-surgeon things. So everybody tells me, like, well, what's a surgeon doing on screening end? But again, it's so important that we do that because that's really the backbone of addressing a lot of these disparities. And certainly last but not least, the American Cancer Society for putting a webinar like this together and supporting it. And I guess I can't forget Pelotonia for all their support. They've supported me in my personal research in my efforts to address some of these disparities and to continue engaging with Black women. So thank you so much for your attention. And I hope we have time for questions. I try to time this very carefully.
Dr. Oppong, thank you so much for your comments. Thank you for helping us frame out our morning. We are going to hold questions until we've done a few more presentations, but we are so grateful for your comments this morning. Thank you.
Thank you.
Our next speakers will be from the American Cancer Society Cancer Action Network. I'd like to introduce to you Robyn Kaltenbach. Robyn is a strategic visionary and a nonprofit leader with more than 20 years experience leading others to exercise their power, make informed decisions, and become agents of change. She currently serves as the Grassroots Manager for American Cancer Society Cancer Action Network, leading a diverse delegation of volunteers to curate and share their personal stories and encourage lawmakers to join the fight to make cancer a national priority. Our next speaker beyond Robyn is Leo Almeida. Leo is the Government Relations Director for the American Cancer Society Cancer Action Network. He leads volunteers and staff across the state through campaigns to achieve progress on evidence-based policy and legislative solutions designed to eliminate cancer as a major health problem. Leo's worked for over a decade on all sides of policy, politics, and legislation. Most recently, he served as the Senior Policy Advocate for the Nature Conservancy in Ohio. Before that, Leo worked for the Ohio Legislature, where he started a legislative fellow and rose to become a senior legislative aide to the Senate Minority Leader. He's also experienced with local and statewide political campaigns. Welcome, Robyn and Leo.
Thanks, Deb. So we're excited to be talking to you today, and we're going to give you a little bit of background about ACS-CAN. I know some of you are familiar, but maybe not everyone. And then we'll talk about our federal and state issues that we support and why health equity is an important aspect of our advocacy work. So if you can go to the next slide. Great, thank you. So ACS-CAN is the public policy advocacy arm of the American Cancer Society. We were started over 20 years ago to ensure cancer is a top priority for policymakers at every level of government, from gaining dramatic increases in federal funding for cancer research and tobacco prevention and cessation programs, to ensuring all Americans have access to cancer care. Our work is saving lives and leading to new innovative breakthroughs in how to fight this disease. ACS-CAN empowers volunteers across the country to make their voices heard and to influence evidence-based public policy that changes lives. As we focus on our advocacy work, we remain committed to advancing policies through the lens of health equity. For ACS-CAN, health equity means everyone has a fair and just opportunity to prevent, find, treat, and survive cancer. No one should be disadvantaged in their fight against cancer because of how much money they make, the color of their skin, their sexual orientation, their gender identity, their disability status, or where they live. Disparities in social determinants of health, like income, access to healthcare, housing, geography, employment, education, and discrimination, must be addressed by policymakers, as these factors continue to contribute to the worsening of health disparities in the cancer continuum, especially for communities of color. While innovations in cancer prevention, detection, treatment, and survivorship have come a long way, not everyone has benefited equally. Research shows that while overall cancer mortality rates in the US are dropping, populations that are marginalized are bearing a disproportionate burden of cancer. If we are going to further reduce deaths from cancer, we need to make sure everyone has the ability to benefit from the advances in prevention and treatment of cancer. So we're going to take a little bit of a deeper dive into some of the policies we support and that we address on breast cancer. And I'm going to turn it over to Robyn to talk about some of our federal policy work, and then I'll come back and talk to you about some of our state level work.
Thank you so much, Leo. First, I just wanted to say how honored I am to be part of this conversation, and thank you to each of the panelists and each of you watching this for participating. I think these are really important and timely conversations, and I'm really honored to be part of it. You know, the work that I do is mostly with volunteers and our community partners, and in part, it's because we've all been or will be at some point in our life impacted by a cancer diagnosis. And while hearing the words "you have cancer," or finding out that a loved one has cancer will never be easier, we work behind the scenes at American Cancer Society Cancer Action Network to ensure that everyone who does hear those words is given a fair and equitable shot at beating that cancer diagnosis. In many cases, the prescribed treatments are determined in the capital, not by the medical experts who are treating the patient, and that's because of the policies that are enacted. So we work with volunteers to meet with, email, tweet, collect petitions, or otherwise engage with lawmakers to create those personal connections through our stories and amplify our collective voices to rise above the noise. As Leo mentioned, we work at all levels of government, and specifically on the federal level, I'm going to talk about the National Breast and Cervical Cancer Early Detection Program. The conversation is timely. I just received a response from an evergreen story collection prompt that we have from a young woman who was just diagnosed with invasive ductal carcinoma. And she's been told several different diagnoses, several different treatments, several different potential outcomes with each specialist she has seen. The problem is that the narrative of the story that she shared with me is not the invasiveness or the prognosis for cancer. Rather, it's the lack of perceived help in affording to care for her young children, all under the age of 18, because she doesn't have access to the resources that she needs while she's unable to work because of the aggressive chemotherapy. Fortunately, just like with Sylvia, her diagnosis was made early. We know that mammograms save lives, and early detection is key to cancer outcome. Unfortunately, many women don't have access to these screenings, so we work with Congress to ensure funding for federal cancer screenings and early detection programs. On this chart, you'll see that there's the percentage of women who've received a mammogram in the last year if they're between the ages of 45 and 54, or in the last 2 years if the woman is 55 years and over. That number is only 63% and 31% amongst women who are uninsured. The real shock is that this year alone, more than 43,000 women will die from breast cancer. Providing access to mammograms for underinsured and uninsured women is just one step towards addressing the staggering statistic. Next slide, please. So in 1991, the National Breast and Cervical Cancer Early Detection Program, I'm probably going to call it NBCCEDP. So if you hear that, it's because it's a mouthful. It was launched in the Center for Disease Control and Prevention's Division of Cancer Prevention and Control. Again, lots of acronyms around here. It is the only nationally organized program, and it serves all 50 states, the District of Columbia, 6 U.S. territories, and 13 tribes or tribal organizations. Through this program, more than 15.6 million screenings were given to more than 6 million eligible people. In 2019 alone, the NBCCEDP provided breast cancer screenings and diagnostic services to more than 286,000 eligible people and diagnosed 2,579 invasive breast cancers. Next slide, please. On this slide, we're going to see the distribution of the services in Ohio that the NBCCEDP provided between the years of 2016 and 2020 based on race. So we see that the NBCCEDP provided 57% or so screenings to white women in Ohio, 23% for Hispanic women, nearly 16% Black and African American women, and less than 3% for the Asian Island or Pacific Islanders. Next slide, please. To be eligible for the NBCCEDP, individuals must be at or below 250% of the federal poverty level and between the ages of 40 and 64. This is specifically for breast cancer screening. The cervical cancer guidelines are a bit different. Less than 2 in 10 eligible people actually receive breast cancer screenings, and there's several reasons for that. Lack of awareness of the program, systemic barriers, lack of trust within the healthcare system. Perhaps the biggest cause, however, is insufficient funding. And that's where American Cancer Society Cancer Action Network steps into action. On the right side of the screen, you're going to see a proud photo of Ohio volunteers meeting with Senator Sherrod Brown's office last year to make several asks of his administration, including increasing funding for this life-saving program. I will save you the boredom and not go into details of the federal budget and appropriations process, but know that we are closely following the process and are relieved that the House Appropriations Committee has finally turned their attention back to the FY23 bill, which is where funding for the cancer research programs and CDC programs live. So in less than 3 weeks, nearly 700 volunteers from across the nation, including, I think there's 17 of us in Ohio, will be traveling to Washington, D.C. to meet with our federal lawmakers to ask for a $72.8 million increase in funding for the CDC cancer programs, including the $31 million increase in funding for the National Breast and Cervical Cancer Early Detection Program, which was funded last year at a flat rate. The work we do at ACS Can at the federal level is only a sliver of the actions taken to reduce healthcare disparities and ensure everyone who hears the words "you have cancer" or fears that that might be their fate receives a test that they need. This means that we're also quite active at the state level, and I'm going to turn it over to Leo, who's going to outline a lot of the work we are doing here at the state level.
Great, thanks, Robyn. And you can go to the next slide. Great. So as I mentioned earlier, we consider disparities in social determinants of health when considering policies that we support. For example, we all know that a cancer diagnosis and treatment often come with a hefty price tag. Many cancer patients and survivors face financial struggles, and we look for ways to help them through public policies. 2 bills that we're currently supporting to reduce the financial burden of cancer are House Bill 135, the copay accumulator bill, and House Bill 608, the biomarker testing bill. House Bill 135 will assist all Ohioans, not just cancer patients, who have high prescription costs by requiring insurance companies to count copay discounts toward an individual's annual deductible or other out-of-pocket cost requirements. House Bill 608 will ensure all Ohioans have private and public insurance coverage for biomarker testing, and I'll go into a little bit more detail about this bill shortly. We also oppose anti-vaccine bills because of the detrimental impact COVID-19 and other illnesses have on immune-compromised individuals. Robyn talked about our support for funding for the National Breast and Cervical Cancer Early Detection Program. Similarly, we advocate for funding for these types of state-based programs. In West Virginia, we've helped advocate for $400,000 in annual funding for the breast and cervical cancer screening program, which works with over 300 providers statewide to ensure program eligible women receive the services they need. In Ohio, we've supported the annual $1.1 million funding for the Breast and Cervical Cancer Project, which serves about 7,000 uninsured or underinsured individuals per year. We look forward to continuing to advocate for this funding in next year's state budget bill. In last year's state budget bill, we joined our partners in advocating for a fix to what was called the wrong door issue. Based on this fix, women who are uninsured, have income that falls under 300% of the federal poverty level, and are under 65 years of age can utilize BCCP Medicaid to cover needed treatment, even if their initial screening for breast or cervical cancer was offered by a provider who either does not participate in or was not paid for the screening by the Ohio Breast and Cervical Cancer Project. Our hope is that through this legislative fix, more eligible women will be able to utilize BCCP Medicaid to cover their treatment. And you can go to the next slide. So biomarker testing is a really important bill that we are working on in several states across the country. And in March of this year, we introduced this bill in Ohio by working with several partners and legislators. ACS Can has been working on this because we know that this is a huge benefit to those who are diagnosed with cancer. So for those of you who may not know, a biomarker is a sign of disease or abnormal function that can be measured in blood, tissue, or other biospecimen. And biomarker testing is the analysis of a patient's tissue, blood, or other biospecimen for the presence of a biomarker. Biomarker testing includes single tests, multiplex panel tests, and partial or whole genome sequencing. The results of a biomarker test can help healthcare providers match a patient to a targeted therapy. Unfortunately, not all individuals benefit equitably from biomarker testing and targeted therapy. Patients who are older, Black, uninsured, or Medicaid insured are less likely to be tested for certain guideline indicated biomarkers. We are working to pass this bill to ensure patients have access to biomarker testing in Ohio in order to provide cancer patients with access to precision medicine and increase the chances of surviving cancer. And you go to the next slide. So as we wrap up our presentation, Robyn and I would like to tell you about an upcoming event and ways to get involved. I'd like to invite all of you to participate in our annual policy forum, which will be held in the State House atrium at 11 a.m. on November 29th. This year's topic is focused on new technologies and advancements in cancer care. This is a free event, but space is limited, so please register in advance. We'll add that registration link in the chat for you. And Robyn, I'll turn it over to you for the final slide.
Thanks so much, Leo. Leo and I have outlined some of the work that we do, but it's really it's a sneak peek at some of the incredible efforts that volunteers across our great state are engaging on. The reality is that we have a lot of work to do and not enough boots on the ground. So in addition to the policy forum that Leo mentioned, which is a really great conversation at the intersection of healthcare and policy, we have a state advocacy day where folks from across the state send down our state capitol and meet with our state reps and senators to make very specific asks in the spring. That's something that we really would encourage everybody to be involved in if possible. We also have a lot of opportunities to learn more about the work that is being done to affect real change. And so we'd like to officially invite each and every one of you to join us in becoming a fighter. You can either scan the QR code or check out some of the various opportunities that we have to engage with American Cancer Society Cancer Action Network at fightcancer.org/OH. Thank you so much for considering this and for lending your voice to the conversation. Make sure if you have questions for Leo and I that you drop them in the Q&A, and we're going to stick around, so we'll answer any questions that we can at the end of the program. Thank you so much. Deb?
Thank you both. We appreciate your comments today, and we appreciate your call to action. There's so much that we can do, and we appreciate the opportunity here. Thank you, Leo and Robyn. So before we move on to our panelists this morning, it's time for our next poll question. We're going to pop this up on the screen and ask that you take a moment to give us the answer to this question. So what do you see as the biggest challenge to breast cancer screening based on your observation? So within your clinic, your setting, what is the biggest barrier that you observe to breast cancer screening? We would love to hear from everyone. If you could give us an answer, and we'll pause just for a moment so that you can have a moment to make your selection and hit submit on the poll. It's fantastic. Results are pouring in. Thank you all so much for your participation in the poll. We'll give you another moment. And this again is a multiple option that you could select, if you will, before you hit submit. Okay, while you finish that, we won't remove the poll yet, but while you finish that, allow me to introduce our first panelist speaker, Dr. Rachel Perrell. Rachel Perrell, PhD, RN, serves as the Program Service Coordinator for the Southwest region of the Ohio Department of Health Breast and Cervical Cancer Project. Rachel has 25 years of experience as a registered nurse with a focus on serving diverse and vulnerable populations in the community setting. She's a recognized expert in community-based strategies to address health disparities and the social determinants of health. Prior to joining Premier Community Health, Rachel served as a tenured professor, teaching both undergraduate and graduate nursing students and engaging in scholarship related to improving health at the community level. In her current role, Rachel promotes early detection and prevention of breast and cervical cancer among underserved women within a 16-county area in Southwest Ohio. In this role, she routinely engages providers and community partners with the goal of reducing barriers to breast cancer screening and prevention. Please join me in welcoming Rachel.
Good morning. It truly is an honor to be such part of such an important conversation and be part of a group of people who are really advocating for the importance of health equity in breast cancer screening. So thank you for that introduction. And I am representing both the Ohio Department of Health Breast and Cervical Cancer Project, as well as Premier Health this morning. We are a little unique in that Premier Health serves as a grantee for BCCP as one of the 4 BCCP regions in Ohio. And I'm going to talk this morning about how this grant funding and our relationship with BCCP has uniquely positioned us as a healthcare system in addressing health disparities in our region. Next slide, please. So this morning, in the few moments that I have, I want to share with you how as a health system, we identified health equity in breast cancer as one of our priority community health needs. And I also want to really share with you multiple strategies that we have used to address these barriers to prevention and early detection of breast cancer. Next slide, please. So again, I'm not going to go all through the specifics of our healthcare system, but we do represent one of the largest comprehensive health systems in Ohio. And again, we cover really, we're far reaching in this southwest part of Ohio. One of the largest employers. And so when we talk about health equity in breast cancer, we're even talking about outreach to our own employee population as well as our region. We cover 5 hospital campuses. Again, very comprehensive outreach in terms of inpatient and outpatient services. And so when we talk about health equity in breast cancer, we're really looking at how do we comprehensively address this issue in this far-reaching expanse that we have in our area? Next slide, please. So as I talk about our strategy, I do want to emphasize that all of the strategies I will discuss really flow from mission, vision, values. And as I reflected on our strategies in my time preparing for this presentation, it really hit me again how important integrating, really making your mission, vision, values part of what you do in that strategy. That these things that we all have as part of our organizational structure are not just words, not just something that we put on a website, but that we find ways to truly integrate these ideals into our work. And so as a mission from Premier Health, we're really looking at extending beyond the walls of hospitals to improve the health of the communities we serve. Many of the speakers before me have talked about the outreach that needs to happen with women in our communities whom we might not necessarily be reaching yet as a healthcare system. We do want people to choose our healthcare system and get the best care that they can get when they do choose us for their services. And then in terms of value, when we think about addressing health disparities, it really does involve a focus on respect, acting with integrity, reaching out with compassion, and again, that focus on excellence. And I really believe a focus on excellence needs to include addressing barriers to health. Next slide. So I included this slide to give you a perspective on our geographical outreach. Now, again, if you're not familiar with the Dayton region in Southwest Ohio, this might not mean as much, but I do want to point out, again, I mentioned we sort of span the reach of 5 different hospital campuses. And for those of you on the call who are part of a healthcare system, you understand as part of those hospital systems, we're talking about many provider offices, primary care, OBGYN associated with those practices. Again, outpatient clinics, cancer treatment centers. There's a very wide network. And so when we talk about addressing disparities, it's really how do we get to everyone and help them understand the resources that we have, and how do we all work together well so that women who are currently underserved are better served, that they actually come in for screening, that we reach them. I also want to point out, as you look at this map, that our hospital systems span diverse populations. And so we, in our somewhat northern and even some of our southern areas, very rural populations. So our Upper Valley Medical Center, we have some very strong relationships through the BCCP program. And we find that women in that rural area, some of the outlying counties, have barriers to access just because of location, of screening centers, transportation issues. Again, there's a wide range of women that we're reaching in these areas, and we have to tailor our strategies based on some of the unique geographical locations that we serve. Next slide. So like many of you that might be on the call who are from a healthcare organization, we all engage routinely in a community health needs assessment. For our health system, we actually did this in collaboration. The cycle was several years ago. We're actually going through it again, but we're pulling from national, local data, looking at what are the trends. Dr. Oppong this morning already talked about some national trends, epidemiology, what we're seeing in terms of breast cancer incidence, prevalence, mortality rates. And so, of course, we have been part of that as a system. We do look at that community level data. We come to some consensus as a system. And again, really that institutional commitment to drilling down into identifying health disparities and perhaps some of those areas where we could make improvements. And so as we looked at our strategies that are kind of bringing us to the current year, we identified a focus on breast cancer health equity that really fell within a focus on chronic disease and access to care. So this is a process that perhaps many of you are familiar with, but something unique that our healthcare system engaged in was some unique conversations in the community. Next slide, please. So in addition to looking at national trends, having conversations within the system, we also went out into the community, particularly to population, African-American population in one of the service areas for Atrium Medical Center, down Warren, Butler County area, with the intent to truly engage members of the population who perhaps have not been traditionally heard when it comes to concerns, questions about engaging with the healthcare system. So this particular important conversation was called Conversations with Our Ancestors. It was actually held on Juneteenth. And this meeting, community meeting, was really intended to be led by community members. It was held at a community center, and it was really a launching point for starting to address health inequities and health injustice that is experienced by people of color. And this was actually a collaborative effort between Atrium Medical Center and our local health department. But again, it was a starting point for understanding what people have to say, to really hear from people in our community about barriers, about perceptions. Dr. Oppong also touched a little bit this morning on just experiences that people have had with the healthcare system and wanting to really understand that so we can do better. So that's something a little bit unique that you perhaps could take from our strategy, is to really find innovative ways to get outside the walls of your organization and listen to community members. Next slide, please. So in my remaining time, I'm just going to quickly touch on sort of from that basis, from understanding what's happening in our communities, from our own organizational commitment. What are some things we've actually done? And again, part of that is a system-wide focus on diversity, inclusion, and inequity. Understanding we need to look at things like racism in healthcare, discrimination, things that have been mentioned this morning already: inadequate pay, lack of time off, lack of health insurance, lack of access. What could we do about some of these things? Next slide. So of course, one of our main strategies to address the issue of uninsured low-income status is serving as a grantee for BCCP. And then in addition to those funds, we actually utilize funds from our hospital foundations that provide for women who are even a little bit higher income. So our healthcare system has really committed to providing BCCP services in our region as a grantee for almost 20 years. And again, we leverage those funds with other hospital foundations and community donations. That's really important. As far as I know, we're one of the only health systems that really are extending our reach to women at that level of FPL. And I think sometimes people think, well, they're making that much money. Do they really need our assistance? But we have found women who still, even beyond those BCCP guidelines, still really struggle to be screened because they really, can't afford it. Again, people have mentioned, people are trying to put food on the table, pay rent. So we're able to offer, that small segment of women some additional help. And then I will say, as a program, we have found that it has been extremely beneficial to develop strategic community partnerships. One example is the Norma J. Ross Memorial Foundation in our area. They have been successful in reaching a diverse group of women that we perhaps could not have reached on our own. Another thing that we have found very successful in recent years, again, I mentioned the complexity of a large healthcare system. There are many people in our healthcare system who would say, I didn't even know we had BCCP existed. We have worked really hard over the last couple of years to hold some very strategic meetings with registration, with billing, to make sure that at every level, when a woman presents to our system who has barriers to screenings, she is referred to us. We don't want any woman to come through our doors and end up with bills who could have been assisted by BCCP or our community foundation funding. Next slide, please. As a healthcare system, we also have a commitment to getting out into the community through mobile mammography. Again, we reach out in both these urban and rural underserved communities. I just visited a provider office in a very rural county, and as I drove there, I realized we were about 30 to 40 minutes from a hospital, and the mobile mammography van actually goes to that location every month. The mobile unit also tries to reduce barriers by having kind of non-traditional hours, such as Saturday times, and then again, leveraging partnerships. We have a FQHC system that has benefited from an ACS grant over the last year, and we partner with them and bring the mobile unit to one of their locations every month. And then just as I finish up here, next slide, please. We've also started focusing on cancer prevention, which has been discussed by several presenters as well. And we do try to make that accessible to low-income women. One of the ways we're doing that is working with an FQHC who works with underserved women, and we're offering that through that program. And then finally, next slide, doing some targeted cancer prevention outreach through social media has been another strategy. So just finally, as I finish, next slide, I think it's really important as a healthcare system, as a provider within that system, to understand that embracing the mission is really crucial. Those strategies will only be successful to the extent that the organization is really committed to health equity and addressing those issues. And then investments in community partnerships really are key. Getting out into the community, hearing the voices of your community members and your community partners, and allowing your community partners to conduct outreach that perhaps you could not do, but you can assist with and benefit from the trust they might already have in the community. So I'm happy to take questions at the end as well, and I've also included my contact on the last slide.
Dr. Carroll, thank you so much for your comments this morning. You've really kicked off our panel with a lot to think about. So thank you. We appreciate your contribution this morning. Our next speaker I have the privilege to introduce is Dr. Tiffany Onger. Dr. Onger is a graduate from the Hematology Oncology Fellowship Program at the Cleveland Clinic. She had the role of the program's Quality and Patient Safety Fellow. During her fellowship, she served as a mentor to underrepresented minorities in the Physician Diversity Scholars Program through Heritage College of Osteopathic Medicine, a role that she maintains to this day. Dr. Onger also formulated a pipeline program between medical school and Taussig Cancer Center to support the matriculation of underrepresented minorities into oncology. Furthermore, she's been involved in medical education, helping to implement a social justice curriculum for her co-fellows. She has led talks on topics such as disparities in oncology care, as well as disparities in clinical research. Dr. Onger will join the breast oncology group this year and looks forward to providing excellent care to a diverse patient panel while remaining active in equality, diversity, and disparities work. Welcome, Dr. Onger.
Thank you so much for that kind introduction, and good morning, everyone. My name is Tiffany Onger. I'm a breast oncologist with a special interest in equity, diversity, and inclusion in cancer care. I am honored to speak with you today on behalf of Taussig Cancer Center at the Cleveland Clinic. Next slide, please. Consider if you were to one day notice a lump in your breast. You know you need to get checked out, but you have neither a doctor to evaluate you nor a home to call your own. Today, I will talk about what the Cleveland Clinic is, how the Cleveland Clinic is working towards equity in breast cancer screening. Next slide, please. So what is meant by that word equity? Equity can be defined as the state of when everyone has equal opportunity to prevent cancer, find it early, and get proper treatment and follow-up after treatment is completed. Next slide, please. As we explore equity, you'll recall that not all differences in health outcomes are unjust. For example, some differences between groups can be explained simply by health differences. Differences in health outcomes due to unavoidable inequalities, such as differences in genetic penetrance. As we see this in patients who carry BRCA mutations. These patients are much more likely to develop breast cancer, not due to a social injustice, but due to the natural process as a result of an inherited genetic mutation. In comparison, health inequities are avoidable inequalities in cancer care. One such example is socioeconomic status. We know that patients who live in rural communities are less able to get to organizations with capabilities to perform high quality cancer screening tests. This is an example of a health inequity. Health inequity is often used interchangeably with health disparity, the term I will use for the remainder of this talk. Next slide, please. The American Association for Cancer Research has identified at least 11 population groups that may experience cancer health disparities. In the United States, it's easy to think of just racial minority groups, but there are many other groups also at risk for disparities, such as individuals of low socioeconomic status, individuals with disabilities, sexual and gender minorities, and those at the extreme of age, to name a few. Patients also experience intersectionality, wherein a person may fall into multiple at-risk groups, which may compound the risk for cancer disparities. For example, sexual minority adults are twice as likely as the general population to have experienced homelessness in their lifetime, and a higher proportion of transgender people report recent homelessness than when compared to sexual minority and cisgender straight people. The risk factor of being a sexual gender minority and being a person who experiences homelessness can compound an individual's risk for cancer disparities. Disparities affect large sections of the population, but what contributes to disparities? Next slide, please. Disparities can come from a variety of sources, collectively called the social determinants of health. Social determinants of health are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Social determinants of health have a major impact on people's health, well-being, and quality of life. One such determinant is economic stability. People with steady employment are less likely to live in poverty. However, disabilities, injuries, and health conditions can make it more difficult for people to get and keep a job. This can leave some in the position of homelessness. At the Cleveland Clinic, we recognize our opportunity to improve the health of the communities we serve. In the next few slides, I'll talk about some of the work that has been done around people experiencing homelessness. Next slide, please. The Northeast Ohio Coalition for the Homeless 2020 report noted that 67% of extremely low-income renter households are considered severely cost-burdened based upon how much income they pay towards rent. A single parent would need to work 74 hours a week at minimum wage to afford a 2-bedroom home in Ohio. Not surprisingly, there are approximately 19,000 people who experienced homelessness in 2020 in Cuyahoga County. According to local homeless management information system data reported through Cuyahoga County's Office of Homeless Services, 5,470 individuals utilized emergency shelter in 2020. Over the same time, 680 people reported sleeping in places not suitable for human habitation for some period of time. Next slide, please. Data regarding cancer screening rates and people experiencing homelessness are limited. At this past year's ASCO meeting, our very own Dr. Killick presented a poster on behalf of her team exploring breast cancer screening in persons experiencing homelessness. Her study examined patient encounters for homelessness from January 2014 through December 2021 at a hospital system spanning 5 counties and a populous Midwestern state. Homelessness was identified by 2 criteria: presence of the Z code for homelessness and the patient's electronic medical record, or an address listed as an address in their EMR listed matching that of a regional homeless shelter, transitional housing, or simply as homeless. For each female person experiencing homelessness within the appropriate age for screening, billing data was reviewed to identify at least 1 mammogram in the previous 5 years. Additionally, data were reviewed for a cohort of people who were not listed as homeless for comparison. Next slide, please. Over 3,000 women experiencing, of the over 3,000 women experiencing homelessness who were found, 1,320 were eligible for a screening mammogram. Demographic data noted that the median age was 53.5 years old, 44% were Black, 48% were white, 8.5% unknown or other race, and 3% of Hispanic ethnicity. 28% of people experiencing homelessness were uninsured, and 67% had government insurance. 66% had an assigned primary care physician. Of people experiencing homelessness eligible for screening mammography, just 18% had at least 1 screening mammogram during this 5-year interval. By comparison, a similar cohort of people not experiencing homelessness had a screening mammography rate of 32%, which was significantly higher, though still not ideal, and we are working on this as well. Next slide, please. Let's take a closer look at the data for women experiencing homelessness and compare those who did receive a screening mammogram over the 5 years reviewed to those who did not, compared to people experiencing homelessness who did not undergo screening mammography. Those who did complete a mammogram were more likely to have an assigned primary care provider. Those patients were also more likely to be, were also less likely to be uninsured. Furthermore, they were more likely to be a non-current tobacco user and a non-current illicit drug user. This study provided valuable insight into the correlations and barriers that may contribute to lower screening rates in people experiencing homelessness. Next, I will share a project that seeks to increase mammogram screening in people experiencing homelessness, the HOPE project. Next slide, please. HOPE stands for Homeless Women Receiving On-Site Mammography, Patient Navigation, and Education. Previous models of mobile mammography have not established follow-up patterns of care for women with abnormal screening results. The HOPE project is an innovative approach to serving homeless women's breast health needs through direct care and education. While mobile mammography is not a new concept, there is a need for more research into the public health impact of such programs. We believe that by pairing mobile mammography with planned locations, patient navigation, education, and wraparound services, our approach uniquely creates a sustained connection to the healthcare system and will provide valuable information from which to model future outreach via mobile mammography. Next slide, please. This project is a partnership with our community partners, and working closely with these organizations and facilities, we're able to reach patients through an avenue that patients already trust. Instead of expecting patients to come find us at our big and complex facility, we're going to where the patients are and feel more comfortable. Our partners helped us to advertise the patients, and when the patients would come to the event, they are invited to participate in a survey if they are 40 years old and older, and they would receive a screening mammogram. After that, they are provided an educational session about breast health by a clinician, and I'll talk a little bit more about the educational session in a few slides. Next slide, please. This is an overview of the project. We identify a community partner, agree on a date, and coordinate our mobile mammogram and our patient navigation services. Once patients are registered and check in, they complete the survey, receive their mammogram, receive a medical consultation, as well as education. There are meals provided before and after, and we follow up with any positive results. Next slide, please. In addition to the mammogram, the educational session is an important aspect of the day. This session is delivered by a clinician. During the sessions, an overview of breast cancer is provided, as well as a review of risk factors and the significance of family history. Women are instructed on knowing their own bodies and the importance of a self-breast exam, as well as the importance of mammograms in helping to identify early stage cancers. The session discusses what to expect during a mammogram and what follow-up might look like depending upon the results. Finally, there's time for Q&A with the clinician. Next slide, please. Pamela Combs, one of our nurse practitioners, said, "People don't exist as parts, they exist as a whole person." We recognize that though this day is really focused on mammograms, we could serve our patients better by providing additional screening services as able. Our dedicated clinical staff enables us to provide these clinical services on the day of and in a one-on-one manner. Participants have a sort of passport of items to discuss, including tobacco use, cervical cancer screening, colon cancer screening, and other necessary referrals such as dentistry. Patients are even given fit cards to complete if they are due for colon cancer screening. Every patient is provided with a primary care physician as well, and they don't have to be through our organization. Our community partners provide an excellent service, and if patients want to see a primary care provider there, we're happy to connect them. Next slide, please. Over this past spring and summer, we have had several events targeting specific areas of the community denoted by zones. So far, we've had approximately an 84% utilization rate. The majority of mammograms are negative. However, there are some positive screening mammograms. Next slide, please. It is during the follow-up phase of the project when our patient navigators really shine. They share results with patients and arrange appropriate follow-up. Sometimes patients have transportation, childcare, or other needs, which our navigators assist in. If a patient misses an appointment, the navigator follows up. Because each patient has their very own navigator, this gives the opportunity for relationship building and for trust to grow. Next slide, please. Finally, survey data will be reviewed from our mobile mammogram clinics. We will review demographic data, including patient race and their history of cancer. We will also ask them how much they agree with a number of statements meant to help us better understand barriers to screening. These data are being reviewed, and I'm excited to share that the results will be presented at ASCO Quality Care Symposium in Chicago, September 30th through October 1st. Though we feel this project has been successful for a population of people experiencing homelessness, we are seeking ways to reach other groups with low screening rates. Next slide, please. The AACR reported in 2021 that LGBTQ+ community members have been shown to be significantly less likely to receive a mammogram due to past negative experiences when seeking medical care. Additionally, lesbian and bisexual women have higher rates of a number of breast cancer risk factors, including increased alcohol use, higher rates of smoking, obesity, and nulliparity. The next phase of our screening mammogram project will focus on the unique needs of sexual and gender minorities. Next slide, please. Finally, I'd like to close by sharing ways that we are seeking to hold ourselves accountable for equity in cancer care. We have recently been selected to participate in the Health Equity Report Card. This is a joint effort by the Cancer Action Network, the NCCN, and the National Minority Quality Forum. They have identified 5 categories for health equity, including community engagement, accessibility of care and social determinants of health, addressing bias in care delivery, quality and comprehensiveness of care, and clinical practice guidelines recommendations. We recently completed the assessment, and the recommendations should be available to us soon. Next slide, please. That's all I have for today. Thank you so much for your time and attention, and for all of your work towards equity in cancer care.
Dr. Onger, thank you so much for your comments this morning. Thank you for sharing the work that you've done and the work that you have ahead. We look forward to staying close to you to hear how that goes. So thank you. Our final panelist this morning is Abby Starkey. I'm so pleased to introduce Abby to you. She is the program manager for the West Virginia University Cancer Institute Mobile Mammography Program and the program coordinator for the Mountaineer Health Initiative. Abby is also part of the WVU Cancer Institute communications team, where she manages and develops social media content for the WVU Cancer Institute and the WVU Cancer Institute mobile accounts. Abby is also the chair of the State Cancer Coalition, Mountains of Hope. Abby has been employed with cancer prevention and control at WVU Cancer Institute since 2017. And during her time, she's coordinated a multidisciplinary lung cancer survivorship program and the West Virginia Lung Cancer Project. Abby earned her Master of Science in Health Administration and her Bachelor of Business Administration and Marketing from Marshall University. And Abby is a lifelong West Virginia resident. Abby, welcome this morning. We're so pleased you're with us.
Thank you. So as you said, I'm Abby Starkey, and I'm the program manager for one half of the WVU Cancer Institute's mobile cancer screening program, Bonnie's Bus. Bonnie's Bus is West Virginia's only mobile mammography program. It was established by a donation from Ben and Joe Statler to honor Joe's mother, Bonnie Wells Wilson, who lived in a rural area of West Virginia, was unable to get screening mammogram, and consequently died of breast cancer in 1992. Joe wanted to ensure that all West Virginia women have access to life-saving screening mammograms for early detection of breast cancer. Next slide, please. 2022 marks our 13th year on the road, screening women from every county in West Virginia. We upgraded the unit in 2017, and the new coach style bus provides 3D mammography. The bus is 45 feet in length, and it's about the size of a large RV. It contains 2 large private dressing rooms, easy access for patients to get off and on the bus, including a wheelchair lift, a GPS system to help staff find our most rural locations, a dedicated registration area that is spacious and private, and a sophisticated communication system providing patients with quick results. Here you can see some of our pictures, our waiting area. This is our staff. We operate on a rotating schedule, so we have 2 of our road crew are traveling, and then the other 2 are back at home doing follow-up and pre-registration for the next visit. This is Jerry, Rick, Kathy, Diane, and Annetta. We have 1 admin staff. Gary is in the back of the picture, and we share him with our mobile lung cancer screening unit. Gary receives all of our schedules from our clinics and then calls patients to do pre-registration. Our mammographers follow each patient from the point of screening until diagnosis or a clear scan, frequently navigating those without insurance back to the West Virginia Breast and Cervical Cancer Screening Program so that they can receive any follow-up procedures. Our road crew reports to WVU Medicine, and all admin and managerial staff like myself, we report to WVU Cancer Institute's Cancer Prevention and Control Unit. We also have some ancillary staff management on either side, and then of course radiologists and laundry service that also go into operating this unit. West Virginia is the only state that is fully covered in Appalachia. We serve the insured, uninsured, and underinsured. We screen in partnership with community clinics at work sites and at 1 correctional facility. No West Virginia resident of eligible screening age is ever turned away due to inability to pay. We utilize grant funding, donations, and we partner with the West Virginia Breast and Cervical Cancer Screening Program to navigate the uninsured and underinsured to coverage. Next slide, please. So this is sort of our process. We partner with the organization and the community. Typically, we are contacted. Someone wants us to come to their area. The community partner, we encourage clinics more than others, but the community partner completes an orientation where they learn what their role will be in the process. The partner is provided with promotional materials, schedules, and a policy manual. The partner then sends the completed schedule to our staff 2 weeks at least prior to the visit. Our staff will then complete pre-registration. That way, if we have never seen a patient before, there's time to build their chart in our EHR so that it just sort of speeds up the process while we're actually there on screening day. Our community partners provide Bonnie's Best with patient ID, insurance cards, the order, and the vaccination record. The patients then receive their mammogram on screening day. The ordering provider will then receive the result via fax, and the patients receive the result in the mail. Our mammographers follow every patient until diagnosis or a clear scan. Next slide, please. This is just sort of our process for following making sure that women get enrolled in BCCSP if they are applicable. So I just kind of wanted to show that it is easier a lot of times for some of our patients or clinics to just say, oh, they're uninsured, can we just pay for that patient with bus funds? But we really want to get them enrolled in BCCSP as often as possible because they will pay for any additional diagnostic other procedures that have to be done, whereas we will only pay for the screening. Next slide, please. This shows our mammograms every year since our beginning year in 2009. I believe it was in 2011, Cancer Prevention and Control actually took over control of managing the schedule and where we would go and dealing with partners in 2011, and our numbers really started to increase after that. Maybe it was 2010. So last year, we screened 2,281 women. As you can see, 2020, we were down because of COVID. We didn't go on the road until May of that year. Next slide, please. These are our total visits per year. We went to 164 visits last year, 120 in 2020. Next slide, please. So our 2021 accomplishments, we had 164 screening days. We screened over 2,000 patients. 437 of those patients needed follow-up. And then patients using donations and grant funding was 182, and we diagnosed 19 cancers. Next slide, please. As a result of our cross-county line screening, Bonnie's Best has screened women from all 55 counties. The only county we have not physically parked in is Pendleton County. Next slide, please. So of course, we always have room to improve and to move forward. Some of our challenges are the no-show rate. We're always battling the no-show rate, although I say all the time to our partners that we have some of the most reminded patients in the field, because they get a letter, they get a phone call, and then they get an automate from they get a phone call from us for pre-registration, they get a phone call from the clinic, and then they also get a phone call, the automated phone call from WVU Medicine. Another challenge is fuel cost, of course. In the last couple of months, it's been very high. So that's always a challenge, but we have done a really good job geographically in the last few years. We start our week at the farthest location and then the farthest place away, and then we move backwards towards Morgantown. And then our request for screening days greatly exceeds our number of screening days available. I currently have about 15 requests for next year. We begin making our schedule in January, and then by the time we go back on the road in March, our schedule is completely full. We screen 4 to 5 days a week. We do screen on some Saturdays, so our schedule remains pretty full, and we have even had several requests from actually outside of the state borders. Our future plans are to identify ways to decrease our no-show rate, and to continue to increase the efficiency of our schedule. Next slide, please. This is just our mobile screening page. For Facebook, we put a lot of information here for our patients and our community members about where we're going to be. We also try and do a little bit of education specifically around lung cancer since it's newer, but breast cancer screening information as well. Next slide. This is my last slide. So this is the future, and this is both of our mobile screening units together. I'm sorry, that was very fast. We have COVID in this house.
Abby, thank you so much. I'm so sorry that your family is not feeling well, but we are so grateful that you're with us today. Thank you for everything you shared.
Welcome.
Okay. So we have just a couple, I'm sorry, we don't have a couple minutes for questions. That's one thing I wanted to let you know is we have moved right through our agenda, but I would love to share with you now a video, a final best practice that we have with our friends at The Ohio State University. We'd love to hear about their program, Turning the Page on Breast Cancer.
Is a new program built to address breast cancer disparities among African American women. Dr. Electra Paskett is here to tell us more.
This program will deliver to women the opportunity through a website to go and determine if they are at increased risk for developing breast cancer. And if they are, it will provide to them suggestions for what they need to do.
Why is there such a need for this?
African American women in the state of Ohio have disparities in death rates from breast cancer. And in addition, they are more likely to be diagnosed with what's called triple negative breast cancer. And that is why we feel that this is such an important area.
How is this program funded?
This program is funded through a variety of sources, Pelotonia, and also from a grant from the American Cancer Society.
Learn more at cancer.osu.edu/blog.
Thank you so much for sharing that video. We appreciate that. So now it's time for our final poll question. Our final poll question is based on your observation among those you serve. Which population groups face the highest barriers to breast cancer screening? And again, you may choose multiple answers before you hit submit. We would love for you to give us your reply to the poll on the screen, and we'll give you just a moment to do that, please.
Is a new program.
We so appreciate you taking a moment to answer our poll. We'll give you just a little bit of time yet to complete making your selections. This information really does help share where we're working. While our final answers continue to come in, and do feel free to provide your answers to the poll question yet on the screen, I'm going to go ahead and start introducing our final speaker for the morning. We're very excited to have with us Ms. Ashley Dedman. Ashley holds a Master's of Public Health from Florida A&M University. She's a certified health education specialist. Ashley is currently the director of the National Breast Cancer Roundtable for the American Cancer Society. Before her role at ACS, she was a manager for the African American Health Equity Initiatives and Metastatic Breast Cancer Initiatives for the Susan G. Komen organization. Ashley has a diverse professional background in government, policy, healthcare, and education. Ashley is a breast health leader, a trained cancer research advocate, and a BRCA2 mutation carrier, and was a teen caregiver of 2 parents with cancer. Ashley is a 2022 Project Lead Institute graduate and has served on a myriad of related work groups, boards, and committees advancing equity in breast cancer, genetic testing, and clinical trials at the local, state, national, and global levels. Ashley was named a 2019 Houston Business Journal 40 Under 40 and 2021 40 Under 40 in Cancer awardee. Please join me in welcoming Ashley Dedman.
Thank you, and good morning or good afternoon, everyone, depending on where you are located. My name is Ashley Dedman, and yes, I am the director for the National Breast Cancer Roundtable. Next slide, please. So today I'm going to talk with you a little bit about Roundtable history and overview, talk to you about the National Breast Cancer Roundtable, a little bit about the collective impact model, as well as ACS health equity principles and how health equity is strategically a part of the National Breast Cancer Roundtable. Next slide, please. The ACS roundtables are a recommended and proven model for breaking down silos across sectors to tackle those challenges, those challenging issues that no one organization can or will address on their own. As a neutral convening organization, roundtables create sustained partnerships, collective action towards patients and providers, and including education and coordinated advocacy around priority policies across the cancer continuum. Serving as the backbone organization, ACS provides the leadership and support to define cancer control problems, plan implementation strategies, and align resources to accelerate change. Next slide, please. All right. The ACS provides organizational support, expert staff, planning, and project management to 6 national roundtables focused on breast cancer, cervical cancer, colorectal cancer, lung cancer, HPV vaccination, and patient navigation. ACS engages thought leaders and multi-sector organizations in the roundtable to engage in collective action planning to implement strategies that influence policies and practices that contribute to the overall roundtable goals and positively impact the experience of patients and their families. Next slide, please. So as we transition into the National Breast Cancer Roundtable, the working aim for the National Breast Cancer Roundtable is to accelerate progress across the breast cancer continuum through strategic partnerships to eliminate disparities and reduce mortality. The Nbcrt works to ensure all women have access to quality screening and treatment, including Black women and women in other historically excluded communities, and to address those social and emotional needs of patients and their families. Next slide, please. And just again, to level set, kind of the do's and don'ts of roundtables. Again, we serve as a neutral convening body. We are here to identify those challenges that no one organization can address on their own. And we respond to the direction of volunteer leadership. We catalyze collective action to advance shared goals, strive to operate in concert with our organizational membership, and to coordinate advocacy around priority policy issues and finally, to operate under transparency and accountability. Roundtables do not duplicate member organizations' roles or their work. And finally, we do not compete with member organizations. Next slide, please. What you see here is a working processing map of the Nbcrt and what we have done to date, and looking forward to as we continue to progress towards our launch. We began our pre-launch with 3 planning cohorts and listening sessions where we brought together leaders in the breast cancer advocacy space, the research space, and practice to serve as the initial planning efforts for the Nbcrt. The goals for the planning cohorts and listening sessions were to really identify the most important emerging and longstanding breast cancer issues a coalition of organizations should address. These planning cohorts help to shape the launch plans, the operational structure, the foundational priorities, and other key decisions of the Nbcrt. Where we currently are, we're currently in our key informant interview phase. We're actually closing it out, where we're partnering with Strategy Arts, which is a planning and facilitation consulting firm with deep experience in public health, where we're working to interview stakeholders in the various breast cancer space through a 30 to 45-minute interview, really diving into really figure out which priorities we need to consider for the roundtable and and the best ways and best practices to address those priorities. And then finally, we're in the process of building out our executive leadership and our steering committee. And then finally, we're looking forward to our launch in October of 22 of this year in Washington, DC. Next slide, please. So on the previous slide, I shared with you that we had our planning cohorts and listening sessions. And what I'm showing you here, we had 3 planning cohorts and listening session, and each cohort was the members of those cohorts were broken down into 2 groups, and they were asked to identify the most urgent, most impactful, and most collaborative priorities that we should consider. And so what you see here is a culmination of all 3 cohort and listening sessions, most urgent, most impactful, and most collaborative findings that the Nbcrt should consider as priorities. And those priorities will be solidified once we identify our executive leadership team and our steering committee. Next slide, please. And what you see here are the 3 individual reports from our planning cohorts and listening sessions. These are our executive summaries that provide that high-level overview and the takeaways from these sessions. And as we progress to the latter part of this presentation, there will be information about our website, which you can find the full information and these full reports on our website. Next slide, please. So some of the next steps for the Nbcrt, of course, as I said, we're concluding our key informant interviews. We're identifying our executive leadership, our steering committee, and building out our membership criteria. We're also identifying inaugural funders and preparing for our October launch. Next slide, please. And then this is just a visual of everything that I just shared, really talking and getting into the maturity and growth of the National Breast Cancer Roundtable in the next year, year 1, year 2, and as we progress into year 3 of the Roundtable. Next slide. And then I want to transition really quickly into collective impact. ACS uses the collective impact model as a structure for roundtables to streamline and unify the processes. The collective impact model is a framework that supports the evaluation of the roundtable impact. The definition of collective impact is a network of community member organizations and institutions who advance equity by learning together, aligning and integrating their actions to achieve population and system level change. The collective impact model has 5 key components. It starts with a common agenda. This means coming together to collectively define the problem and create a shared vision to solve it. It establishes shared measurement. That means tracking and progress results in the same way, allowing for continuous learning and accountability. It fosters mutually reinforcing activities, categorized by differentiated approaches and willingness to adapt individual activities and coordinations through a joint plan of action. It encourages continuous communication that supports building trust and strengthening relationships and partnerships. And it has a strong backbone. That means having dedicated staff with the resources and skills needed to convene and coordinate participating organizations to align with the work of the group. And next slide, please. Again, ACS serving as the backbone organization. As we look at this slide, the first 2 focus on guiding the vision and strategy for roundtables to consist on issues and agenda. The function of supporting aligned activities focuses on coordinating, convening, and facilitating partner engagement and collaboration in activities that forward the agenda in concert. Next, we have establishing shared measurements and practices and building public will. The focus on shared approaches and data across partners and having a call to action and consensus in the community. Lastly, we have alignment in the policy agenda across partners and mobilizing funds to support the roundtable's goals. Next slide, please. And finally, here we have our health equity principles. ACS roundtable teams and the ACS health equity team are working together in tandem through an internal health equity learning collaborative to develop a roundtable specific health equity framework. This supports the ACS roundtables by providing a space for roundtables teams to learn more about health equity, develop roundtable specific health equity frameworks, and to share other health equity best practices, challenges, and successes. Next slide, please. And here are a few key takeaways for today, as well as a time for questions, but I think we're going to get to questions later. But here's some takeaways for today. And thank you for my time. Thank you for the time. Oh, last, I do have one more slide. Thank you. This last slide is the QR code to our website as promised, where you can find those executive summaries from our pre-launch strategic planning, and as well as the website where you can go and get additional information and learn how to be involved and engaged in the NBCRT. And finally, we have our NBCRT team. In the middle, we have our outstanding program director, Teresa Now Petey. She's married. We have our managing director, Sarah Schaefer, and then myself, director.
Ashley, thank you so much for your comments this morning. We really appreciated hearing about the National Breast Cancer Roundtable and the development of it. We're all excited to stay tuned for membership opportunities. So thank you very much. In closing today, I know we have about a minute of time. We had hoped to get to some live Q&A. We did not. If you'd like to still put questions in the Q&A, feel free. Our speakers will address them there, and we'll be glad to follow up. We will also send out a video that we have on our Reach to Recovery program that'll come with the wrap-up materials, and we'll pop it in the chat. We'd love for you to take a look at that. Let me just remind you quickly that we have another forum coming up yet this fall on lung cancer screening. Right after this session, you'll be asked to complete a post-event survey. Completion of the survey is required to receive your continuing education credits. The CME certificate will be sent out in 2 weeks. You'll also receive a post-event email with a recording of today's session and the survey link. We're so pleased you joined us today. We hope you'll save the date for November 3rd and register for that session. Thank you so much to our speakers and everyone who presented this great information. Thank you for your commitment to fighting a world without cancer. Have a wonderful day, everyone.